I'm Clayton Yates, and I'm joined here by Dr. Renee Reams from Florida A&M University, and Mr. A.J. Merriweather, who is our community and patient advocate. Dr. Reams, welcome.
Thank you.
All right.
It's great to be here.
Nice to have you. So can you tell us a little bit about your research and what you have going on at Florida A&M University?
Sure. So the study I want to tell you and the audience about is a comparison of gene expression profiling of tumors, prostate tumors, in black patients compared to white patients.
Like you just said a big word.
A big patient. Yeah, okay.
You said a big word, gene expression profiling.
Okay, gene expression profiling.
Can you clear that for us?
Yeah, okay. So what I really want you to know is that all of us humans have 30,000 genes. So that's a lot of genes. So it turns out at the time that I got ready to do this study and was looking at why prostate cancer is a health disparity in black men, as I looked around and saw that no one had asked the question, are the tumors in black men different? What's driving them? And so the question is, are the genes in those tumors differently expressed than in white men? Just a simple question, but I looked and it hadn't been done, so I wanted to do it.
Very nice.
Yeah.
And what were your findings?
So we were able to get prostate tumors from black men who have volunteered them, and this is all IRB, approved, as well as white men. Now, it turned out that there were not as many samples, so I had to call it a pilot study. But since it hadn't been done, I figured this is a good way to get going. So we got these tumors, extracted DNA, and so we then did an experiment called cDNA microarray to figure out which genes were turned on, which ones are turned off. And like I said, we have 30,000, and it turns out, so a gene is a piece of DNA that is going to essentially make a protein.
And explain the genes in relation to this microarray.
Okay, so actually I have a little picture.
Great.
So here's a picture. And this is a computerized, generated picture of the experiment. And so if a gene is turned on, you'll see a red circle. And that circle
so this would be a red circle here.
Exactly.
Okay.
And that actually
means it's increase.
on. Is on.
It's on.
Yeah,
Okay.
it's on. Right. And so look at it as a light switch. Light switches go off and on. Now put a dimmer switch on that. So sometimes you can crank it almost all the way up, almost all the way down. So red is on or up, express, and then green is not express or decrease. And yellow equal expression. Okay. So anyway, so this will allow us to see which genes, since we all got the same 30,000, are turned up, which are turned down, and is there a difference between black men and white men? And not only that, because these genes have been annotated, which means that you can put them in categories, groups. It's like, okay, so these genes do this, these do that. So we call them ontologies. You can group them. We can figure out the name of that gene and which group it belonged to.
Which gene is on
yes.
or increase, or which gene is not. Okay,
Yes.
really interesting data.
Yes.
Okay, so we're all interested to
I
find out
know.
the results.
Drum roll. So what we found, which was really striking, was that there were a group of genes called interleukins, which is part of our immune systems, that were really upregulated. So they show up as red in the prostate tumors of black men,
All right.
but not in white men.
So this word interleukin, can you?
So these
what
interleukins-
family? If you had to explain that to a layperson, what do you mean interleukin?
They probably understand your immune system, something that protects you. So it meant that genes that have to do with our immune system are more upregulated in the tumors of black men.
Okay.
But not in white men. And so this means pretty much that these could be targets or genes that we would want to regulate and possibly use a type of therapy that has to do with immunotherapy.
Wow.
Yeah, so this was really kind of big.
Very big.
And it turns out, even though this was a pilot, it's been replicated in studies that had 100 times more samples than I had, and they found the same thing.
And they found the same thing.
From
different people?
Different people across the U.S. of A.
Across the USA?
Yes.
Wow, that is really amazing.
So it's just really great. So I was glad I, didn't just say, oh, I don't have enough numbers. So was able to do it and got there.
Very good. Good for you.
Thank you.
Mr. Merriweather, do you have any questions for Dr. Reams?
Dr. Reams, I want to take it outside the box a little bit.
I knew I could count on that.
In that study, when we comparing those genes compared to our white counterparts, were we able to even take it one step further when we can take a family, a sibling that has two siblings, or anybody in the family that has, compared to the same over? Did we get the same results? Or have we even...
That's my next study. That's my next study, and I'm trying to find a cohort of families to find out if this propagates itself. You know, it's also seen in families. So that would be great. Because I often get asked the question, I call it a Mr. Gaddy question. He goes, so all my brothers, my uncles, my daddy, but not me. So, you know, what's special about me? You know, so that's a great question. So the question would be able to, can we get families of men with prostate cancer, and including those family members who don't, and do a gene expression profile on them? That'd be great.
So I have a question for Dr.
Okay.
Is it possible today for a man to know his gene expression profile?
It surely is.
Oh,
It
really?
is. It is. And in fact, if and when, you know, hopefully, if a man were to get diagnosed with prostate cancer, I would say to him, you know, listen after they say the word cancer, and ask, are there clinical trials? Because if you get enrolled in a clinical trial, that's the first thing they're going to do. They're going to do a biopsy, and they're going to actually do a gene expression profile of your tumors to figure out just kind of pretty much what it said. What genes are turned on and off, and do they already have therapies that can target those genes?
The genes that are on or off?
Genes that are
Is
on.
there a match?
Yes,
with
exactly.
the therapies?
Exactly.
Okay.
So and the reason why you want to do that is you want the best therapy first. So you don't want to go off and start taking stuff, and in fact, they, you know, generally probably won't accept you for a clinical trial if you've already tried something, because they're going to give you a standard of care. But if you ask to see if you're eligible for a trial, then you get to choose between, you know, the best possible cases. So that's when you can get your tumor characterized.
All right.
Okay.
Did
that help?
Yeah. Oh, it's clear, but I got to throw you another one.
All
now.
right. Okay, I'll catch it.
I got another one that's probably doesn't have anything to do with it, but I'm curious.
Okay.
If we're saying we are African descent,
Mm-hmm.
and we're doing this with black men in this study and white men in this study, how would that, if you was to throw that ancestry test in and you say, I want to find my gene where I'm from, and me and you say, well, we from America, we from Africa, and then all of a sudden the test come back and say, well, you're a Caribbean, India descent. How would you think that affect the whole study?
You know what? You just need to be on my grant writing team, because that's the next study I'd like to do. I'd like to look at black, native-born black men and their African ancestors, which would be Afro-Caribbeans and then Nigerians, just because that's the population that I'm looking at, and do that same study. And then actually, actually it's in the works to actually characterize what we've done here, their tumors, and see if there's, similarities. Yes, and the reason why I think there is because I compared black and white, and I saw very differences. So now I'd like to look at populations that are more ancestrally related to native-born black men. Okay, and now we're going to throw into the mix what you just asked. I may be self-identified black, and when I do my DNA, it'll show me that, I'm really from, I guess Finland or whatever, and, I'll be disappointed, but that's my ancestry, right? So, but it's important because your ancestry does help predict, and then I'll go look and see, well, what are these states and Finnish people, so I can watch out for it.
Because I would wonder, Doc, just what we talking about. If we took one of them tests, you say, well, I always thought I was whatever nationality, and all of a sudden they come back and say, well, no, you part native.
Yeah.
Then you say, well, wait a minute, I got 40% Native America, because in my family we have down from my grandfather, we have that, so I be like, well, I'm black. But then my grandfather, he was half Cherokee, and I look at him and I look at me, well, hey, I don't have that kind of hair, and I'm curious,
but
just
what
how that
what
mess
if
it up.
those genes from your African ancestry are actually the ones that promote this, that, and the other, so they would still drive what's going on with your prostate cancer. Now, something else may drive what goes on from the Indian ancestry, but they will probably still drive. Right. So I think that, well, you remember the one drop rule,
Mm-hmm.
But anyway, so I think if you have any African ancestry, it's going to be, and that would be the beauty of doing the native-born black and the foreign-born black men, just to see comparisons.
Where they fall at.
Mm-hmm.
Oh,
Yes,
okay.
exactly.
But regardless of ancestry,
Yeah.
your gene presentation at the time of diagnosis determines the treatment.
That is true. That is true.
Regardless of your ancestry as to where you're from, the gene presentation at the time of diagnosis determines what treatment you have.
Right. So once you get your tumor characterized and it tells you that this is the group of genes that are up and these are the bad guys, then that's what you get treated with.
Right.
Yeah.
And are there any opportunities? I know you mentioned clinical trials. What if a man is not enrolled in a clinical trial and he just wants to know his gene expression profile? Is that possible?
Their ancestry or just their gene expression
Just
profile?
their gene expression profile.
Tumors. Okay, right, because it's not going to give up no regular tissue, right? Let's see here. Well, I guess if they've done biopsies and they want to donate their tissue for experimental work and science work, which is what we really need, then yes, that can happen.
Yeah.
Yes, and we need that to happen.
Right.
We really need for black men to donate their tissue. So if you've elected to have your tumors removed, that hospital will keep those tumors on file. But you can also tell your doctor, I'd like to participate and donate my tissue for work. And then people like myself and Dr. Clayton, we're always. He's always calling the doctor to see if he has any tissue.
And see, that's the thing. I learned so much from y'all here, but I never knew that you could request that. It in our community it's not well known.
Let me ask you this: when you go get your new set of tires, and you're gonna get 4, right? And but one is still good. What you do with that one that's still kind of good?
I keep it.
I hate it because it's yours, right?
Right.
And that tissue is yours.
But
you can say what happens to it.
Right.
You can say, do not use my tissue for anything, or you can say, I'd like my tissue to go for science.
Now let me take it this step.
Okay.
When we're going through that, now let's keep it real now.
Okay.
When you first get that diagnosis, what you're saying makes well sense. Now I'm
After
when
the
I'm
fact,
out there,
right, yeah.
I'm gonna be telling guys, if you get that, I would like for you to consider that. But during that process, that comes with that education in our community that we must find a way, even what you're saying for the research, to help us take it to the next step. We need those tissue samples. Most doctors are not going to tell the patient unless they're, and in the community that I'm from, that's not on our priority list to ask. No, our priority list is, I got it. Can you get it out? And what is my quality of life afterwards? But I like what you're saying. So now I got another selling tool to work on.
Yeah. And this purpose of this digest is to get the word out, because our papers go into journals, and so our colleague Dr. Dennis says, oh no, the people that need to know this, I want to figure out how to get it to them. So it's this digest.
And that's why we're here.
Yeah.
I also want to leave as far as, because we sort of hit it, but we didn't sort of comprehensively discuss it, is that you can request your genome. Now, it's a cost.
Wow.
There is
From
a
your
cost
doctor?
from your doctor.
Okay.
All right. There's a cost if upon a primary diagnosis. There's a cost. You're going to have to pay for it. If the tumor recurs, your insurance will pay for it. Okay, it's standard of care to have your genome sequenced.
Oh, very
but you're going to
good.
have to cost that first, and that's standard of care approved by the FDA currently.
That's in small town USA. You can do that.
Yes, you can request any doctor can request that.
And they'll give you the data.
Your doctor would then have to go find the resources to do that, but you have that right as a patient to request your genome to be sequenced. Now, again, as a upon initial diagnosis, you're going to have to pay for that out of your pocket.
But it's worth it because.
But insurances won't pay until after if it comes back or recurs.
Right.
Okay.
But it's worth it because that would help when you're making your decision, right?
It helps you make a decision.
So you get it, and
so
you
have
can
a
say,
clear
can I
picture.
find somebody who can tell me about this? And if they say, well, I see that you've got signatures that say this and this, we have some clinical
Match you
trials
up with
for
the
that.
right therapy. Or match you up with the right existing therapy.
Yes.
Oh,
Isn't that amazing?
It's amazing because you know this, but it's wonderful to hear it from both of y'all. Now, the thing is, if we can translate that information down the line and get that word out, because I never heard that before from Dr. Yates or yourself. And there's a lot of this stuff, I really believe it can help. One, we need you to save your tissues.
Yes.
Two, you can request that your
you get a profile.
Be saved. It's going to cost. And then another thing is, who pays for it? You already said that.
Yeah.
How can we assist in, if we have a way to be able to say, well, we need this, and we want to be able, it's a network over here that can help you.
Exactly.
I really do like what you said, and
Yes.
I think it could go further if we can get the word out about that. And that's where I going to strive to get that word out.
Excellent. Especially among families and among men, like you, I think you talked earlier that men don't talk about it. So if they don't talk about it, I won't find my families, you know, the groups that I need to, you know, donate some tissue.
And hopefully men will tune into our digest.
Tune in. Yes.
All right. And
Please,
so,
please.
thank you, Dr. Reams, and
You're
thank you, Mr. Merriweather. So that concludes our latest edition of the Minority Prostate Research Cancer Digest. I hope you guys tune in to us next time, and thank you.